Hey guys, this is Dr. Singh again, back with another USMLE question review and analysis. Let's get right to it. Again, start with the question stem, last sentence of the whole paragraph. Which of the following is the most appropriate next step in management? So we got another management question here. So a 35-year-old woman is evaluated for a persistent fever 4 days after admission to the hospital for treatment of pyelonephritis. She has type 2 diabetes, poorly controlled with insulin. She has received ciprofloxacin since admission. Okay, results of initial blood cultures are pending, and then now we have a set of her vitals. So temp is 40 degrees Celsius, 100.4, pulse is 110, so it's tachycardic, a little tachypnic, so respirations are 20, and normotensive. Let's just call that normotensive. Exam shows marked right CVA tenderness or costovertebral angle tenderness, which is following is the most appropriate next step in management. So, a couple things with the question. So, she came in for pyelonephritis. She was treated with ciprofloxacin for 4 days, right? She came in 4 days ago and still has a persistent fever. So, ciprofloxacin, for the most part, is covering most of our urinary organisms, which are gram-negative organisms. So ciprofloxacin should be okay here. Not the best antibiotic I would choose, but should work. But essentially, they're telling you that, hey, something's going wrong. She's still having persistent infection and persistent sepsis, shown by the temperature, tachycardia, and the tachypnea. Now, a couple things come to mind. Number one, did the pyelonephritis turn into a renal abscess or a perinephric abscess? Right, and we know abscesses, antibiotics don't touch abscesses for the most part. Really, you need source control with some sort of drainage, some surgical procedure, like a urologic intervention or an IR-guided drainage. Another thing to consider is if this is pyelonephritis secondary to an obstructing staghorn calculi, and that big huge stone is not letting the urine pass, well, that septic urine needs to be drained. If just imagine you got your renal pelvis filled with this massive stone and that infected septic urine is not passing, well, it's still infected, right? So some sort of drainage would be indicated there. So let's look through the answers. One of my attendings in the ICU during my residency kind of would ask this famous question, and he would always say, "What's the best antibiotic?" And everyone would say, meropenem or vancomycin, and he would laugh and say, "No, the best antibiotic is cold steel or source control." And that's kind of the point of this question, is that if there's some sort of abscess there or some sort of thing that needs to be drained, well, antibiotics like ciprofloxacin are not going to touch it. So addition of clindamycin, I'm only adding clindamycin to medication regimens for certain infections, any sort of like toxic shock type syndromes or severe skin and soft tissue infections for the antitoxin component. Vancomycin, I doubt that this UTI is being caused by MRSA or some gram-positive organisms. UTIs generally are gram-negative, so I don't think A or B are very interesting. Let's move on to D, Doppler ultrasound of the lower extremities. This would be to diagnose a DVT or deep vein thrombosis. And it's interesting that DVTs and just clots in general can cause a high fever, but not this high. 104 plus, she's tachycardic, plus she still has the CVA tenderness. What that really shows me is that she's still septic from this pyelonephritis, which has turned bad and needs to be drained. They also don't mention anything about her having, lower extremity swelling or redness or anything like that to suggest DVT on physical exam. Repeat blood cultures, it's probably the second most correct choice here. I would say. You already have blood cultures that haven't come back. If you had persistent bacteremia, blood cultures growing positive organisms, and you checked again and they were growing again, then you would say, hey, maybe our antibiotic choice isn't correct. But I think checking the blood cultures again right now, especially if the first one haven't grown anything, would be kind of useless at this point. So the answer here is C, CT scan of the abdomen. And again, we're really just checking to see is there something that our antibiotics are not touching here? So is there a renal abscess, a perionephric abscess? Is there some big staghorn calculus? Is there some extrinsic compression? Is this a young lady who's got some big tumor that's some pelvic tumor that's compressing her ureter, and the upstream septic urine isn't passing, which is causing her to have a perpetual infection that's not getting better with antibiotics. So imaging her belly and her pelvis with a CT scan is the next best step here, and eventually hopefully getting whatever is going on in there, that obstruction relieved, if it's an abscess drained, if it's a stone removed, and that sort of thing. So that's kind of the premise of this question. If you guys have any questions or comments, please leave a comment down below, and I can kind of help answer those questions. If there's a particular question you guys need help with, or a topic that you would like to be covered, please just write a comment down below, and we can get to it. And thanks so much, and see you guys soon. Bye-bye.